Heading into this episode, I thought I kind of knew what a pain doctor did, and essentially, I just kind of thought it's like you're throwing out, pharmaceuticals to people, a lot of narcotics and things like that. Maybe not narcotics, but just heavier kind of pain medications. And learning about you and your work has really opened up kind of my eyes as to what pain medicine actually is. So, in your words, what do you do, and how do you practice medicine?
Yeah, so I am an interventional pain physician, and so I am pretty broad spectrum. I have been classically trained in how to manage chronic pain from a number of perspectives. Yes, the everybody thinks about is medications. I mostly try to utilize non-opiate strategies. I try to minimize or avoid those if possible. I'm a proceduralist, and so I do, injections or advanced procedures, ablations, and implantable devices, and other minimally invasive techniques to manage pain. But and I incorporate things like physical therapy, and I try to get people plugged in with other resources like chiropractic and acupuncture and psychotherapy and all these things. And as I got into my practice, however, I started to become more interested in the nutritional element. A lot of people know this now, but as a medical student, we don't get any training in nutrition, and what we do get is the typical dogma that we've been given for a long time that, quite frankly, to me, hasn't really worked. You know, just like most people in my position, I think in this space, I came to this through my own journey. I came out of my own training and fellowship after my residency. I was 40, 45 pounds overweight. I was didn't have very much energy. I wasn't sleeping well. I had joint aches and pains. I was sort of depressed, and I stumbled across, I don't even know who it was originally. It might have been Gary Taubes. I can't remember exactly. Then I started to go down this rabbit hole and started to notice improvements in my own health using some of these strategies. Um, and then simultaneously, I was seeing patients in my clinic who were struggling with these things, and they weren't getting good advice. They maybe needed a knee surgery, but they were, 100 pounds overweight. And the knee surgeon would say, well, let me know when you lose 100 pounds, and we'll do this for you, but didn't give them any help with it. Right. And so slowly I started to educate myself more. And then the pandemic hit, and it gave me a whole lot of free time. And so I started to actually get formal training through the Nutrition Network, as well as the Society of Metabolic Health Practitioners. And I actually did all the CME to be obesity medicine certified. I just never took the exam, um, honestly, because I didn't really see a need to by the end of it. And so I started utilizing this stuff in my practice more and more, and started seeing people get better. I was able to take people off some of their diabetic medications, or reduce them. I see people come off their diet or their blood pressure medications somewhat regularly. Their weight improves, and you got to remember, my patients don't have the ability to exercise very much. It hurts, so they're limited in terms of what they can do. So eating less and exercising more doesn't really work for them. Um, and in the process of them improving some of these things, they started to tell me their pain got better in some ways, or they were able to do more. And that totally flipped a switch in my mind about how I wanted to practice medicine. So I always make sure people know that what I do is not a panacea, meaning it's not going to be a cure all. It's not meant to, I don't want to overpromise or overstate what this can do for people, but it can help the vast majority of my patients, in my mind, in a way that doesn't involve pills or injections or surgeries or something more invasive. And so that's, a bit of a long-winded answer for, that's how I think about this.
Wow, that's amazing. As you look back on witnessing some of the other doctors in this field tell people they need to lose 100 pounds, how many times did you see the patient go, "Oh, I need to lose 100 pounds? Oh, got it. I had no idea. I'll just go out and do that right now. Like, thank you, doctor." Like, was that
Yeah.
ever a response?
I mean, the response was usually like anger or depression, or they were just like, they gave up. And, they would get referred to a bariatric surgeon maybe. And there's a place for that. I'm not going to say that there's not. But in my mind, if you have that done and you don't address the dietary piece, you're just going to set yourself up for failure later on. I've actually had some people suggest that if they're on the cusp, like on the border of needing, qualifying for bariatric surgery, I've had some people encourage them to gain weight in order to get to that threshold. And so I just looked
Nice.
at this and I said, this is kind of crazy. We can do better. Um, and, but again, we are not trained that way. Even the bariatric folks sometimes aren't trained that way. And so it took a little bit of a reorientation in my mind.
Yeah. Okay. Well, thank you. And I want to clarify that point as well. In no way are we trying to blame any of the doctors in the
No.
industry. You're trained in what you're trained in. If you didn't get the information, of course, you're not going to have a better answer. So, in your mind, as you go back to when you were, kind of discovering low carbohydrate at the time, what did you think about being healthy or eating healthy? Was that part of your consciousness that you should eat healthy and that might help with pain, or was that just completely off the table?
I didn't really pay it much thought until I started to notice it in myself, right? I've had both of my ACLs have been reconstructed from, injuries in my college years. And I was, I just felt like an old man. I was, having knee soreness in the morning and, I felt swollen and all these things. And I started to notice that lift. And so that was the beginning of it. And then as I went down the rabbit hole with this sort of thing, you start to realize, okay, well, a low carbohydrate or ketogenic approach was utilized for seizure treatment many years ago and still is today. That's 100 years that it's been used for that reason. And I mean, so many of the nerve pain or pain medications in general that we use are seizure drugs. And so, you start to connect the dots with that. And then you find out that, well, people with diabetes or metabolic syndrome have consistently elevated inflammatory markers. And so all chronic pain is in some way inflammation, in some way nerve dysfunction, some combination of those things, among others. And if I've got an intervention like low carbohydrate diets that will improve the components of metabolic syndrome without exception, and is a seizure treatment, why wouldn't that help with chronic pain, or at least give people a chance to? Again, there's no guarantees. I think of things in probabilities in terms of what can I do to increase somebody's probability or odds that they're going to feel better. And I think that's what this does for the vast majority of people that I see.
Vast majority. Yeah. I mean, it's pretty low hanging fruit if you can get somebody to want to do it. Obviously, it involves a lot of behavior change, and we have talked about that as well. But going back to your own personal story, what kind of trepidation did you have? I mean, what little nutrition education you got, through the years, what were some of the things that concerned you? Were you worried about things like cholesterol or, eating tons of fat in the diet? Like what concerned you?
Um, Honestly, at that point, I think I had already started to realize the things that we had been given to understand for a long time were not true. I mean, I had done the low fat, the low calorie, fasting to a degree. I wasn't really fasting like like we think about it now, but exercising myself to death, which only gets harder as you get older. And I had had all those things in the back of my mind. I had tried vegan for a little while. I mean, I had done so many different things, and I didn't really think about the consequences because I was seeing so many benefits in front of my eyes. I mean, the first 4 months that I did this, I dropped 20 pounds without even touching the gym once, and I wasn't even time restricted eating. I wasn't doing any of that. That just came more naturally as I was like, well, I'm not hungry in the morning. I don't need to eat unless I'm, feeling like I need to. And so, I was seeing all these benefits, and I later start to go down the rabbit hole of like, well, what is the cholesterol situation? As my patients would ask me about it. And I started to make sure I educated myself a little bit more. I'm not a lipidologist by any means, but I've got a decent handle on it after all of the research I've done. So
Yeah. Gotcha. So that kind of came later. So from where you are today, since this topic is so hot and everybody's talking about it, we just talked to Dave Feldman on the show. Would you be worried about somebody coming in as that kind of lean mass hyperresponder phenotype where, they have very low triglycerides, very high HDL, and also have very high LDL? From where you are now, again, not medical advice, you're not a lipidologist. From what you understand about it, would you be concerned?
no, no, I don't think so. I don't think we have any evidence to say that. Dave Feldman I consider him the expert in this. I just listened to a podcast he was on yesterday. Um, the way I think about this, and he talks about this very eloquently in one of the talks he did. If you look at the Framingham data, which is the largest longitudinal data set that we have for heart disease in this country, mostly men, unfortunately, but anyway, if you look at that data and specify the things that you mentioned, low triglycerides, high or normal HDL, no weight problems, no hypertension, and no diabetes or prediabetes, your total and LDL cholesterol doesn't matter in terms of your heart disease risk. And that's what he's finding out with the most recent study he did, Dave Feldman, with lean mass hyperresponders compared to people with familial hypercholesterolemia. It seems like neither of those groups have substantial plaque burden when it comes to their coronary arteries. And the plaque burden that they may have does not have any correlation to LDL cholesterol. So the way I conceptualize this is we have a list of risk factors that are much, much more predictive of heart disease. So smoking, right? Far and away, probably the number one. And then after that, you've got diabetes. And then following those things, obesity and hypertension. And then when you look at the cholesterol numbers, triglycerides and HDL, LDL cholesterol is way down that list. And so I look at it like, why focus on this one relatively small risk factor that doesn't have a very strong association if all these other things are much more important? And the vast majority of my patients have many of those other things. So it's almost like missing the forest for the trees to me. Now, I saw a patient the other day who we've been working on things. She hasn't really committed fully to what I want her to do. And she doesn't have diabetes, which is hypertensive. She's got a little bit of weight concerns, and her triglycerides are 150-ish, and her HDL is 46, let's say. And her LDL is 250. And I said, all right, here's your choices. We can keep working on this stuff, and I guarantee we'll get your triglycerides down. Your HDL will be as good or better than it is now. We'll get your weight in a better place, maybe get you off your blood pressure drugs. But if you don't do that, then you probably have to take a statin, right? Because if you're not addressing these other risk factors, yeah, you probably have to do something to reduce your risk, which there may be some evidence for those statin medications in that case. And so everything's individual, right? No two patients are the same. And I definitely don't tell them to do anything without consulting their primary and doing their own research. Because at the end of the day, I'm not a cardiologist. But I think that if we're overly worried about this LDL total cholesterol problem when we've got bigger fish to fry.
Yeah, not a cardiologist, but pretty decent explanation there. Very good.
And Dave Feldman does so much better than I can, but most of his thoughts on this, I think, are on the money, and I think it's much, much more complicated than LDL cholesterol. You know, I use the analogy. Worrying about LDL cholesterol is sort of like blaming the spackle for whatever put holes in your drywall, in my mind, where what happens typically, is my understanding, is the body, the blood vessels in the heart will get damaged from something, smoking, diabetes, high blood pressure, whatever. And it has to come back and kind of fix those damages. And part of that is some platelets and white blood cells, but also cholesterol, among other things. And so the answer to that problem is not using less spackle, reducing your LDL cholesterol. The answer to that problem is stop putting holes in your drywall, right?
Yeah.
So maybe that's not the best analogy, but it's the best I got.
Pretty darn good. I really appreciate that.